We're going to give it a few more minutes for people to come on. Okay, I think I'll get us started. Okay, clearly I need to get rid of this. And that should be better. Yes, it is. Thank you. Welcome. I'm Ellen Andrews from the Connecticut Health Policy Project, and we're with Sheldon Tallman, who's also a panelist today. We're going to be talking about Connecticut's plans or consideration of plans to move Husky back into managed care organizations to run it. We are recording today's webinar, but all visitors and questions are anonymous, so feel free to put questions in the Q&A. We're not doing raise hands. And at the end of this, we'll have time for questions, and then also we will stop recording to talk about ways to have everybody's voice heard. So starting with this, what's being proposed? Let's start there. Governor Lamont is exploring returning to MCOs to run our Husky program, our Medicaid program that covers almost 1 million people now. Those explorations are happening in private meetings without critical stakeholder or legislative input. They have come to MAPOC, but not for general input. We believe that sunshine is critical to good policy making, so we created at the Connecticut Health Policy Project NoHuskyMCOs.org to inform Connecticut about what's at stake if MCOs come back to Husky. We'll talk about what happened before when Husky had MCOs and why they ended, what the evidence since then says, and how to get your voice heard. So what is an MCO? It's easy to forget that many of you weren't around when we had MCOs in our Medicaid program. Medicaid is our Connecticut state program, providing, everybody probably knows this on this webinar, providing healthcare coverage to low-income families, individuals, seniors, and people with disabilities. MCOs are managed care organizations hired by a state to run their Medicaid program. They are private insurance industry company plans, and they are very profitable. MCOs are paid on a capitated basis. That means that they're paid a per person flat fee to cover all necessary care for their members. If the costs of care are lower than what the state pays them, they get to keep the extra as profit. But if the costs of healthcare are higher than the fee, the MCO will lose money. MCOs can make money by keeping people healthy so they don't need expensive care, or they can just deny needed care. Currently, Connecticut runs our Medicaid program without MCOs. We pay providers directly for the care that they give members without any middlemen in between. So what happened back in the day when Husky did have MCOs? Governor Rowland first hired MCOs to run Connecticut's Medicaid program in 1996. That was before we had a lot of the information that I'm going to show you about what happens, what that means. But during that time, between 1996 and 2012, when they were removed, a state study found that 4 out of 10 providers listed by the MCOs did not take MCO patients. Enrollment in MCOs was regularly suspended because they didn't have enough providers to care for members. An audit by the Comptroller's Office found that the MCOs were overpaid by millions of dollars. It turns out they underestimated. And Connecticut's doctors were suing the MCOs for engaging in, this is a quote, I should have put it in quotes, deceptive and improper practices that harmed patients. and the state could not get data from the MCOs. This was, as I was staffing the MAPOC at the time, this was a massive problem. We couldn't get data from the MCOs to hold them accountable for the quality of care. We always heard about apples and oranges and how you really couldn't compare anything. In frustration, in 2012, Governor Malloy ended the MCOs and moved to our successful care coordination model that helps members manage their care and stay healthy. So the question now, it's 2024, do MCOs improve access and quality of care? Now, you should know that 40 states use MCOs for their Medicaid programs. So we actually have a good amount of information about whether they do improve care. And the answer is, frankly, no. Despite many years and many studies, there is no evidence that Medicaid MCOs either improve access to care or the quality of care that members receive. And that's according to MACPAC, the federal Medicaid oversight agency. That's also according to many other independent groups. Connecticut Medicaid now without MCOs is among the highest states in terms of the quality of care that members receive. Do they save money? Again, no. Connecticut has saved billions of taxpayer dollars since 2012 when we ended the MCOs in Husky. Our cost control is now the best in the nation. We spend, as just one example, looking at administrative costs, we spend 2.75% of program costs on administration compared to the US average of 8.5%. So we're about a third of what they spend. Compared to other states with MCOs, Connecticut spends 7.7% less of our state budget on Medicaid. This is important because Connecticut is a 50% match state because of our higher incomes. That's only, most states get higher match than that. So the fact that we're spending less is even more important since we have to pay half the costs. That 7.7% frees up $4 billion in funding in our state budget for other priorities. Despite many years and many studies, there's no evidence that MCOs save money for states. The inefficiencies, this is just a short list, include advertising. We don't have to advertise. Federal MCO taxes. There are taxes states are paying back to the feds for MCOs. We don't have MCOs, so we don't pay that tax. Administrative costs, as I talked about, state agency costs to manage all the contracts, overlapping and duplicate functions between MCOs and with the state. The cost to collect, harmonize, and report data from multiple MCOs, which is non-trivial, and profits. Despite significant ACA enrollment increases from 2016 to 2022, per member spending in Husky has been very stable, when in the rest of the country, it's gone up significantly. Also, this is from the Kaiser Family Foundation, or KFF now. It is a very innovative program. This is a mix of, I think it's probably a dozen, maybe 10 different kinds of innovations and focus areas for innovation according to states. I put the circles in on their graphic, but Connecticut is the only state that is cited in every single focus area. Even without MCOs, we are very innovative, maybe because we don't have MCOs. And in 5 different payment models that KFF points out, we are currently innovating in 4 of them. We've adopted 4 of them. And when we have the maternal bundled payments, we will have all 5. This is a really important study, and I'm going to stop here for a little while. Researchers, I did a lit review, and you can go to knoWhuskyMCOs.org to see all the studies that I could find. There are dozens of them, maybe 100. But one study, and this was really point on, that was published just in January, compared, it was done by an oncologist at Wayne State University in Indiana. He's frustrated by trying to get cancer care for his patients and in a managed care environment, in Medicaid managed care that they have. So he wanted to compare states with and without And he looked at to try and find paired states that were similar socioeconomic and demographic metrics, and he's compared Connecticut and New Jersey. Now you can see that between 2007 and up to 2011, this is early stage cancer diagnoses over time. We're about the same. You can see after that in 2012, it starts going up for Connecticut. We actually are up 4% now when New Jersey's did not change. And 2012 is when we got rid of the managed care organizations. Now, early stage diagnoses is up 4%, but survival from cancer, 10 solid tumors, is up 8%. That's people who are living, who aren't, and frankly, in New Jersey. So great question. Why do most states use MCOs for Medicaid? If it's better, then why are they doing it? It's easier. States with MCOs outsource a lot of their administration and complaints from the state to the MCOs. When we were under MCOs in Connecticut, you'd call up about a problem that's affecting one or more people. You'd be just referred to the MCO. And then when the patient got there, trying to get an external review, a truly independent review, is extremely difficult, as the OIG has documented in a recent study. They do it also because it's more predictable. They do know for a year per member per month what people are going to cost. But there's still a lot of enrollment variance. Recessions happen, COVID happens, changes happen in terms of the unwinding. So the budgets really are not all that predictable. They change a lot. Plus the next year, you may have saved, even if you manage to save some money one year, they make it up in the next contract. It can be very hard to move large bureaucracies from MCO contract management back to direct program management. It took Connecticut a year. It was painful for people at the state. And it took 12 years of advocacy against some strong lobbying to get Connecticut back to MCOs. And other states have tried and have not been able to do it. And here it needed a new governor to take a fresh look. And also in some states, Medicaid is working very badly. Fee-for-service Medicaid has been neglected. And so MCOs in those states can actually improve quality and access to care. But that is not true in Connecticut. We are actually doing exceptionally well in terms of cost control and also getting people care. And I think it's really important to point out that almost all large employers in Connecticut and nationally, including Connecticut State Employee Plan, do not use capitated MCOs because of cost and quality reasons. So what can happen for members if we do bring back MCOs? And Husky members have a lot to lose. Husky right now is in the top quarter of states in 17 out of 28 adult quality measures under Medicaid.gov federal quality measures, and 13 out of 22 child quality measures. Cancer detection, as I pointed out, and survival improvements could be lost. It is likely to be harder to get appointments for care, and there will be fewer providers accepting Medicaid patients at all. That happened in the past, and when we got rid of the MCOs, providers came back into the program, and they dropped their lawsuit. There will be more administrative hurdles to get the care that you need, more delays, and less access to independent reviews to reverse denials, as I said. You may lose coordination of care through primary care providers and intensive care management. Those are both programs in our fee-for-service program that traditionally are in MCO states are run through MCOs. People may not be told about better but more expensive care options with more provider risk. The MCOs may find ways to keep you from even knowing that there's better care for you. And these problems will fall hardest on seniors, people with disabilities, and communities of color that will increase health disparities that we're already struggling with in our state. So what would MCOs mean for providers? Well, the long-awaited provider payment rate increases that we had the first study on, and we're waiting for the next one next year, will be at risk. Providers will have to negotiate their payment rates with the MCOs. And I know they're really looking forward to that. You may have seen Donna Nicolino did a very great op-ed in CT Mirror describing her challenges working in New York and Connecticut's MCO, New York's MCO and Connecticut's non-MCO Medicaid programs. And she is a behavioral health provider for trauma care. And she talks about how she's had to drop 2 of the 3 MCOs she was participating with in New York. So we will probably lose providers, especially in behavioral health. We really can't afford to lose any. People will likely see more prior authorizations and denials, as well as delayed payments. The administrative burden for providers of submitting claims to multiple MCOs. The feds require that we have more than one MCO, usually 2 or 3. And as providers leave the program, there'll be even more demand for the care for those who choose to stay. We'll also lose a lot of opportunities right now, and this is just a short list. Connecticut Medicaid is working with stakeholders on committees. Many of you I know are on some of these committees with DSS to improve primary care and connect people to community services, increase the low provider rates to improve access to care, expand access to mental health and substance use care, and support justice-involved members to improve lives. Right now, we can design and implement those programs directly. Under MCOs, the policymakers would have to negotiate with the MCOs to implement them and get it into the next contract, which could be a year and a half out. And the MCOs would likely profit from the savings generated by the programs that we design. So I'm wrapping up. Connecticut should not bring MCOs back into Husky. We'd expect lower quality, higher costs, so we'd be paying more and getting less. We'd lose opportunities. There would be fewer providers available, and care would be denied, and more administrative hassles. So what can we do? We can go to nohuskymcos.org to keep updated on what is happening. You can sign up for updates. You can get the evidence, and we are updating that and adding to that as we go. We have fact sheets in English and Spanish. We have talking points. You can get answers to your questions, and you can join others concerned about how MCOs in Husky would affect the program and the state. So you can learn how to make your voice heard. So you could feel free to put some questions up, but I will turn it over to Sheldon if he has something he'd like to say.
Thank you. Can you hear me? Great summary. There's a lot more, but that hits on all the key points. And we did have experience with this, so it's not like a hypothetical. It's real. We saw it happen. And Ellen talked about the various ways that they effectively deny care. And the way I like to summarize it is there's 3 basic buckets. It's have not enough providers, so you can't even get into a provider to get started. If you manage to get into the provider, they impose all these administrative hurdles, particularly prior authorization. And that works not just to deny care, but providers self-censor, and they don't even bother requesting because they've done it before and they know it's a lot of work and it's often denied. So, that's that. And then lastly, even if you get into a provider and even if you are able to get the provider to request prior authorization and they get it, the provider has a great difficulty getting paid for the approved service. And what the consequence of that for providers is cost. And therefore, they're far less likely to participate. And that was a major problem when we got rid of them. There were a lot of providers that came back, including providers whose rates did not go up at all. It's the same rates. They were willing to do it because of the lower administrative hassles. The other thing I wanted to call your attention to is this thing about administrative costs, which are very high. I know Ellen's slide said 8.5%. That's based upon a DSS estimate. But when we had the MCOs, it was much higher than that. So it was routinely higher than 10 or 15%. was coming off the top, not going to healthcare. And what does that mean? Well, it means our folks are denied something. Even if the costs were the same, as Ellen showed, the costs are higher overall for the state taxpayers. But even if the costs were identical, given those high administrative costs, including profits, you can see that there's going to have to be less care in the end in order to meet those profit guidelines. Another thing I wanted to mention for those who haven't made the connection, some of you may have already done this, is how this is very similar, not exactly the same, but very similar to the situation going on right now in Medicare, where about half of the Medicare population has now been moved into capitated MCOs. They're called Medicare Advantage plans, but it's basically the same. And we have all of the same issues. And members of Congress are starting to notice, advocates have been noticing for a while, but are noticing that the quality of care through it, Medicare Advantage plans is worse, and it's costing the taxpayers more. And lastly, I wanted to call your attention to a big question. This is sensitive, and this is being recorded, so I'll be a little guarded in saying this. But why? Why? And legislators have asked me this. Why, if we already been there, done that, didn't work, it was expensive, the care sucked, things are much better now, it's far more accountable, it's not fragmented, why would we consider going back to it? I can't answer the question, but I can point out a couple of things. One is we have information that at an organization called the Democratic Governors Association, the MCOs are very prevalent with sponsorships, and they are lobbying to tell Democratic governors, perhaps Republican governors as well, about how wonderful their plans are. It's called marketing, right? And another thing is that there's an organization called CareBridge, which is a for-profit home and community-based services provider. And I have an article I'm staring at from a couple of years ago announcing that CareBridge announced, and it's going to sound irrelevant, but you'll quickly see why it's relevant, announcing a $140 million funding round led by an organization called Oak HC/FT, with participation from 4 of the nation's 5 largest Medicaid managed care organizations. Now, why is that interesting? Well, CareBridge exclusively serves full risk Medicaid and dual eligible Medicare, Medicaid patients needing long-term support services. So basically, CareBridge is a contractor with only with full risk MCOs. And then I want to point out this last piece from this article, which says that, quote, CareBridge is revolutionizing care for individuals on Medicaid receiving home and community-based services. That's a quote from Brad Smith, who's the executive chairman of CareBridge. And then it says, quote, when I first met Brad Smith 7 years ago, I immediately knew he was the kind of entrepreneur we wanted to invest in, close quote. That quote is from Annie Lamont, co-founder and managing partner at Oak HC/FT, said on LinkedIn. We invested in his first 2 companies, and today we couldn't be more thrilled to announce that CareBridge secured $140 million in funding. And again, that was from these MCOs, capitated MCOs, such as the ones that used to work in Connecticut and Medicaid, and this organization called Oak HC/FT, co-founded by Annie Lamont. So you can draw your own conclusions, but we have that background potentially having something to do with why this is currently being proposed. Thank you.
I'm muted, aren't I? Thank you, Sheldon. So anybody who wants to should put a question in the question and answer, and you can upvote other people's questions, but we do have some from people who are not on today, who couldn't make the, well, people who aren't on today. But one is the timeline. What's the timeline for this? And unfortunately, don't really have an answer for that. Right now, we were hearing about an RFI that appears not to be imminent for sure. There may be a study coming on this. And we certainly don't know of any public hearings or opportunities for the public to weigh in on this yet, but we will let you know if you sign up for updates. Another piece of this is there's sort of an assumption that insurers are behind this, and I think I need to put that I need to make, and I'm speaking at the state level here, that the insurers here in Connecticut did not ask for this. They were not pushing this. They told me that, and I believe them, that the governor approached them about it. It's entirely possible, as Sheldon talked about, at the national level, that insurers were promoting this. Another important thing is to note that this comes from the governor himself, not from DSS, not from OPM, not from some of the agencies. So I think that's important to note. I mean, they work for him and they're going to do what they have to do, but this didn't originate there. So the status right now is to let the governor know that we don't think this is a great idea, and hopefully be able to slow this down or stop it. Another question about that comes up is somebody said, well, it couldn't be any worse in a meeting I was in. I was like, oh, you actually can. We didn't, and if you want more, I haven't done the troubles yet, but that will be in the up on No Husky MCO. But it is true that the program has lots of room for improvement, and a lot of you all have worked hard on trying to improve the program. It is, but I think right now we talk to legislators and to state agency folks who live here in Connecticut and work here in Connecticut, not for national managed care companies that have to go to the mothership for, resources or to change policies, and frankly have to be paid to do it. So things really could get worse. We have a question. I will not say from who. Will the proposed change require legislation, or can it be done by executive order? Actually, the answer is, well, maybe Sheldon. Should I leave that to you? Sheldon's the lawyer.
That's a great question. And let me answer it by telling you what we've been told an answer given was by somebody else. An answer given by the lawyers at DSS to the governor's office was, yes, it needs legislation. We cannot do it based upon what's in an existing statute. I will say that I've looked at those statutes and they are problematic as they stand in terms of authorizing some contracting with MCOs. And frankly, those laws are on the books because nobody thought to remove them after we moved on. So we now have two sets of statutes. We have statutes authorizing DSS to contract with non-risk administrative service organizations. We really didn't talk about that today, but our structure involves administrative service organizations paid on a non-risk basis to do some of the tasks, limited tasks that insurance companies used to do, the MCOs used to do. We have statutes authorizing the contracting with them, which is what we're doing, but we also have in the books these other statutes. So it's kind of a mess, to be honest. But at least the lawyers at DSS who looked at it felt that, and they may know more than we know about what exactly the governor's thinking of doing, but they have told him that our understanding is that they told him that what he would like to do or what he's thinking of doing would require some legislative action by our legislature, which is good to know.
Right. There's also been a question about NEMT, Sheldon, and why that's different than the other systems. And do you want to answer that one?
Sure. What I just said a moment ago was a lie. Not all of the contractors under Medicaid are ASOs. They used to be. So there were 4 ASOs when we first rolled out the non-risk, non-capitated state taking control program on January 1st, 2012. One was for behavioral health. At the time was called Value Behavioral Health. One was for dental services called Benicare, which we still have and still is non-risk. And the third is Community Health Network of Connecticut, which, by the way, was one of the capitated MCOs. And frankly, they're the ones that did the best job. That nonprofit, statewide homegrown entity took over and got the contract to do the lion's share of the administrative services on a non-risk basis, and is still doing that and doing a good job of it today. And they're the group that, for example, runs the intensive care management program that Ellen referenced. The fourth was non-emergency medical transportation. That is to say, transportation to get to and from medical appointments paid for by Medicaid. And this was initially a non-risk contract. There were problems with it, but rather than addressing the problems, the state, in a sort of microcosm of contracting with MCOs, decided to put out an RFP to contract on a risk basis for that particular service. And since it did that, the service, and people may recall Vail, that's the original company, has been bought out now by MTM, has been nothing but trouble. And the complaints are extensive. And there are, various reasons for that. But one of the obvious ones is, well, if it's coming out of their pocket every time they pay for a ride, maybe they don't have such an incentive to make sure the rides happen. So that's where we are specifically and only with NEMT. The other ASOs still are working on a non-risk basis and seem to be doing a good job. And that's whether they're profit or not profit. That doesn't seem to be the big issue. The issue is, what are the financial incentives? And these entities are not paid extra if they deny care.
Great. And I know we've had questions before about local versus national MCOs. Other states that are doing really well with their, or doing well-ish with their MCOs, tend to have local nonprofit MCOs, often provider-driven, that sometimes only serve Medicaid clients and maybe exchange clients. Connecticut doesn't have that. We have large national multi-state MCOs, and those states don't tend to do as well with MCOs. And I've also gotten a question around regulations have changed over time. So in the last 12 years, the feds have not been asleep. They have changed the regulations. And there are things like back in the day, there were managed care organizations could take 40% off the top as administration, and the MLR, the part that they spent on the medical loss ratio. I love those insurance terms. Is the amount that they spend on actual medical care would be just 60%. Well, states now can require that they spend all but 15 or 20%, like ACA plans. However, OIG has found that they are often, the compliance with that is very low. They don't, MCOs don't even give the documentation basically to demonstrate that they're doing that. So even though things have changed in some ways, they're still not great. And also the problem that we had, we're only 4 out of 10, about half of providers on the MCO's provider panel lists weren't part of participating, much less taking new patients. That is not unique to Connecticut, and these phantom provider panel lists are still a problem nationally. So it's not to say that things have been worked out. I'd say no, not really. And if we went back in, we probably see a lot of the same things that we did in the past.
And if I could add, Ellen, in terms of the history of regulation as well, when we had MCOs, sort of the dynamics there, and this is, I've heard from colleagues in other states, this is quite common. Once the state has made the decision to contract with MCOs, and Ellen had the slide explaining, the reasons why they might do that, there's an interest, institutional interest in preserving that, right? And what happens is power shifts to the MCOs. So you can have good regulations on paper, but if the contracting state agency has no interest in enforcing it, guess what happens? We had some of the best contracts in the country. We had really, really tight, strong contracts, both on coverage and procedure. And they were basically serving suggestions to the MCOs. They routinely ignored them. And when we tried to get the state to enforce these very clear regulations, oh, well, we've got a lot on our plate, whatever. But what was really going on is the MCOs were saying, don't even think about it. Don't even think about coming after us because, we don't have to be here. And in the end, in the last round, we had three MCOs. That gives a lot of power, right? That if you don't give us what we want, we're out of here. Ellen didn't talk about how the negotiations, they always seem to get more than increases than the legislature even authorized. They just somehow managed to get more. That's what it was like. So regulation in theory could be very, very helpful. In practice, as we had in Connecticut, and I've heard from colleagues in other states, it just sort of doesn't happen.
That's yes, actually, in fact, at one year in an election year, the legislature passed the feds would not let us give more of a because they're paying half the costs at big as much as the MCOs wanted for an increase. So the state passed a tax break for the MCOs on their commercial plans that was proportional to their Medicaid enrollment, which is well, as a good government advocate, really pains me. Anyway, I don't see any more questions. So actually right now we are going to stop the recording. And if you have more questions, first we'll stay on and we will start talking about what we can do and strategies and things that you can do to help. And you can also send us questions whenever you like in the future. And thank you so much. So I'm going to turn off the recording.